In today's class, we will try to learn the pharmacology and some basic points about bisphosphonates. We will try to learn some physiology about calcium and related concepts about calcium homeostasis and all. Okay, so we will discuss bisphosphonates pharmacology in today's lecture. See, first thing, what do you know about bisphosphonates? Can anyone tell me what is bisphosphonate or what are bisphosphonates? Drugs used for treatment of osteoporosis. See, when the term bisphosphonates comes, phosphonates means they are phosphate containing compounds. Okay, first very important point about bisphosphonates is they are the analogues. They are analogues of pyrophosphates. Pyrophosphates, you know what is pyrophosphates? Pyrophosphates are the compounds which are containing p o p. Okay, the compounds, two phosphates which are interlinked with one oxygen, so these are pyrophosphates. Okay, so bisphosphonates are analogues of pyrophosphates, and in bisphosphonates actually these bisphosphonates are they are they are actually analogues of pyrophosphates, but their chemical structure is little bit different because they are having two phosphates and these two phosphates are interlinked by carbon. So PCP, the O is interchanged with carbon. So the compounds which are containing PCP, these compounds are called bisphosphonates. They are called bisphosphonates. And the general term bisphosphonates bisphosphonates are commonly used for osteoporosis. Why they are used for osteoporosis? Majorly these bisphosphonates are used as anti resorptive drugs. You know what is anti resorption? We have bone resorption. Okay, anti resorption is nothing but the drugs which are used to preserve the bones. The drugs which are used to preserve the bones, or the drugs which are used to save the bones are called anti resorptive drugs. So they are having anti resorptive action on bones. Bisphosphonates are having anti-resorptive action on bones. That's why they are commonly used in osteoporosis. They are used in some conditions where patient has hypercalcemia. They are used in conditions where patient has abuse of corticosteroid abuse करने से क्या होगा? Bone density decreases. So in that condition also these bisphosphonates can be used. They are not drug of choice, but they can be used. So bisphosphonates are analogues of pyrophosphates. They are commonly used as anti-resorptive drugs in bones and mainly used in osteoporosis. Clear? This is the basic thing about bisphosphonates. Second year वाले याद रख लो about bisphosphonates. I think this concept is very new to you. You should remember. Okay. So in bisphosphonates we have some examples. In bisphosphonates we have, याद रख लो, these names you should remember. Pamidronate, which is starting from P, pamidronate, and the second example is alendronate. Pamidronate is used as IV infusion. It is available only through IV form. Alendronate is available in oral form. And we have Zoledronate. Yaad rakh lo, Zoledronate. Again, Zoledronate is available in IV infusion. We have Etidronate, which is available in oral form as well as IV form. It is available in both the forms. And we have Tiludronate, which is available in oral form again, and Residronate, which is again available in oral form. Just try to remember all these examples with a simple mnemonic as PASET. PASET is the term which is usually termed for disease. There is a disease which is called Paget's disease, P-A-G-E-T-S, Paget's disease. Actually, Paget's disease is a condition. It is a bone disorder where bones are degraded due to some autoimmunity or due to some factors. We don't have exact cause for this Paget's disease, but Paget's disease is nothing but it is a bone degradation disorder. So in Paget's disease, commonly we can use bisphosphonates, right? Because in Paget's disease, bone is getting destroyed. So bisphosphonates can be used in this condition. So just try to remember this mnemonic. With this mnemonic, you can remember these drugs. Apart from these examples, we have many other examples uh, based on their functional group. See, we have so many examples here, but we don't use all these drugs. Okay, we have etidronate. See here, this is the basic chemical structure of bisphosphonate. Just now I told PCP. Okay, so here we have on the carbon chain we have R1 and R2. If R1 is OH group and R2 is CH3 methyl group, then that drug name is etidronate. So like that we have so many examples. In medicinal chemistry we will learn all these things. So chlordronate, tiludronate, pamidronate, neridronate, olpadronate, alendronate, ibandronate, residronate. This is important. Residronate and zolendronate. So these are commonly used. Presidronate, Zoledronate, and etidronate is also used sometimes. And alendronate is again, it is used in IV form. Okay. So these are the different examples of bisphosphonates. So based on their functional groups, they are named like this. So this is just for information purpose. Okay. I think you all are following me. These are some examples of bisphosphonates. So now let us try to understand how bisphosphonates are acting in the body. So what is the mechanism or what is the mode of action of these bisphosphonates? So before understanding the mechanism of these bisphosphonates exactly, let us try to learn some basic things. In previous classes, I think I explained you about uh, vitamin D, because PTH, vitamin D, PTH, calcium, and FGF23. FGF23. This is also called. Can anyone tell me what is FGF23? FGF23 is fibroblast growth factor. Okay, so these are very important factors, or these plays very important role in maintaining calcium homeostasis. In maintaining calcium homeostasis, we have vitamin D, PTH, calcium, and calcitriol. Again, calcitriol. Calcitriol is vitamin D. We have the hormone which is released from the parathyroid gland, calcitonin. So these are different hormones: calcitonin, fibroblast growth factor 23, calcium, PTH. PTH is parathyroid hormone, and vitamin D. So these are the important hormones and vitamins which will maintain calcium in the body. See, just try to understand this flow chart. This is very important. In next classes it will come. I will explain in detail about other disorders. Okay. So see, first very important thing is 1,25 dihydroxy cholecalciferol. It is called dihydroxycholecalciferol, which is also called vitamin D3 or calcitriol. 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 It is the active form of vitamin D. So this vitamin D, it is potentiating the absorption of calcium from the GI tract. This point we already know. Okay. Vitamin D के functions क्या है? First very important function of vitamin D is it improves or it increases the absorption of calcium from GI tract, right? So all the story is starting from here. See, in the GI tract, calcium is getting absorbed with the help of vitamin D, and this calcium is again, it is getting converted into bones, and for that again vitamin D is potentiating. Vitamin D is again helping for increasing the density of calcium. So this is the second function of vitamin D. Vitamin D, what it does, it helps in increasing the density of bone. This is second function. Now you see here, parathyroid gland has very important role in maintaining calcium, in calcium homeostasis. Parathyroid hormone plays very important role. You know, this vitamin D, which is calcitriol will decrease the release of PTH. So this is the third function of vitamin D. याद रख लो. Vitamin D का third function क्या है? It decreases the release of PTH. I think you all are following me. See, vitamin D has great importance in maintaining calcium homeostasis. In that, first function of vitamin D is it improves the absorption of calcium from GI tract. Second function is it increases bone density, and third function is it will decrease the release of PTH. PTH means parathyroid hormone from parathyroid gland. Actually, this is a thyroid gland. In thyroid gland, we have four different parts of parathyroid gland. Okay, so from this parathyroid gland, parathormone is released, which is called PTH. So this PTH is released when patient has hypocalcaemia. अगर किसी भी पेशेंट में हाइपोकैल्शियमिया है तो then it will be released. And this vitamin D always tries to decrease the release of parathormone. So parathormone release को कौन रोक रहा है? Parathormone का release is stopped by vitamin D. If our body has enough vitamin D, our PTH level is always controlled. When our body decreases vitamin D, when we face vitamin D deficiency, immediately parathormone level gets increased in our body. And what this parathormone does, you know, parathormone will go and act same like vitamin D to improve the calcium absorption from the GI tract. Okay, so this is the function of PTH. And again, one more function is there for PTH. It will try to destroy the bone, and it will try to bring the calcium into the blood. See here, this arrow, it is representing that PTH is potentiating the destruction of calcium, destruction of bone, and it is bringing the calcium in the blood. Okay, I think you all are following me. So this is the first function of vitamin D and function of parathormone. Now you see there is another hormone called calcitonin. What calcitonin does, you know, calcitonin stops breakdown of calcium from the bones. Simple it is, calcitonin is having anti-PTH action. Anti-PTH action. Same like anti-vitamin D action. Actually, anti-vitamin D in bone it is showing anti-vitamin D, but here in GI tract, PTH is showing same like vitamin D. Anyways, you just try to concentrate here. Calcitonin shows anti-PTH action. And calcitonin is released when calcitonin is released when patient has hypercalcemia. Okay, and calcitonin tries to decrease the calcium from the serum. Anyways, अब देखो, till here we understood. Now you see here, in previous classes I was explaining you the synthesis of vitamin D. विटामिन डी सिंथेसिस के लिए what we need, kidney is very important. Kidney converts 25 hydroxy, 1 hydroxy group, 25 hydroxycholecalciferol into 1 comma 25 dihydroxycholecalciferol. 1 hydroxy group is added by the kidneys and it converts the inactive form of vitamin D to active form of vitamin D. This point we already know. Now you see here PTH is also important in conversion of vitamin D. This point I didn't explain you. You have to concentrate here. So to make this point very clear, let me go to the next slide. See, I think this slide I have already explained you. Try to remember this slide. See, uh, this is the pathway. We have two pathways. Mainly these are two pathways for synthesis of vitamin D. We usually follow this pathway. This pathway is seen in plants. I mean from the plants, and this pathway is seen in animals. Okay, so this is the pathway of vitamin D synthesis. See here what happens, first 7 hydroxy cholesterol, it is a cholesterol. This cholesterol is present in liver as well as in adipose tissue. Okay, in adipose tissue we have cholesterol. This cholesterol is converted into cholecalciferol, which is inactive form of vitamin D3. This cholecalciferol is converted in the presence of sunlight in the skin. This cholecalciferol again goes to liver, and in liver this cholecalciferol is converted into 25 hydroxy cholecalciferol. This is 25 hydroxy vitamin D, 25 hydroxy vitamin D, which is also called 25 hydroxy cholecalciferol. And again in kidneys what happens? In kidneys this 25 hydroxy cholecalciferol is again activated totally into 125 dihydroxy cholecalciferol. 1 comma 25 dihydroxy, two hydroxy groups are added. I mean one is already there in liver, one is added in liver, and the second one is added in kidneys. So this is 1 comma 25 dihydroxy vitamin D, which is also called calcitriol. So this is the active form of vitamin D. Now this reaction is seen from the cholesterol which is present in the skin. That means this total synthesis process is occurring in animals, especially in all mammals. In all mammals this synthesis process occurs, and our skin, liver and kidneys, these three are important in manufacturing vitamin D. We can't depend on other sources for vitamin D. Our body itself produces vitamin D with the help of cholesterol. This occurs in animals. Now you see this plant related vitamin D synthesis I will explain now. So this is ergocalciferol, which is commonly seen in plants. We have so many plant sources, like we have nuts, cashew nuts, we have peanuts. Okay, all the nuts contains some form of cholesterol which is called ergocalciferol. This ergocalciferol, which is taken from the plant sources, is entered into the liver. In the liver this ergocalciferol is converted into 25 hydroxycalciferol, and again this 25 hydroxycalciferol in the kidneys, it is converted into 125 dihydroxy ergocalciferol. Okay, so here we have to add ergo because it is ergocalciferol is obtained from plants. So whenever we take ergocalciferol from plant sources, this ergocalciferol will be converted in our body into vitamin D2 form, active form, which is called 125 dihydroxy vitamin D or ergocalciferol. These two forms are very similar. Both of them are active form, but it is called vitamin D2, which is obtained from plant sources, and it is called vitamin D3, which is synthesized in the animal. Both of them are synthesized in the animal tissue only. But the primary source here, the ergocalciferol is coming from plants, and here cholesterol is coming from the skin, from the animals. That's it. So these are two different processes through which vitamin D is synthesized in our body. Vitamin D2 is obtained from plants, vitamin D3 is synthesized in the animals. Clear? Now you know the difference between D2 and D3. We have D1 and D4, D5 also. Anyways, those different other forms of vitamin D are not that much important, but you remember this. In most of the formulations, we synthesize vitamin D as ergocalciferol only. Okay, and when ergocalciferol dietary sources of vitamin D2 are given, always remember that patient is having liver function as well as kidney function. If anybody is not having proper liver function and kidney function, in those cases ergocalciferol is not suggested, because to activate this ergocalciferol into vitamin D2 active form, liver and kidney is important. You have to remember this. Before suggesting to the patients, we have to make sure that it is active form or inactive form, and patient's kidney and liver function is also maintained. Now you see it is very important here. You understood the vitamin D concept, PTH concept, calcitonin, actions of calcitonin also. Now here this concept also we have seen, the activation of vitamin D by kidneys. Here one important thing, apart from kidneys is activating 25 hydroxycholecalciferol into dihydroxycholecalciferol, right? So here in this process, PTH is also important. Don't forget, PTH is also important in activating. Indirectly, it is helping in activating vitamin D. First point. Second, here you have to remember, just now I told FGF23, fibroblast growth factor. Fibroblast growth factor. This growth factor is showing negative action with PTH. That means it is decreasing the activation of vitamin D. Yaad rakh lo, FGF23, what it is doing? FGF23 is stopping the activation of vitamin D3. If anybody is having vitamin D deficiency, in that cases we have to make sure that patient's kidney function is improved. And second function what we have to do, we have to decrease the action of FGF23, right? अगर किसी भी patient में vitamin D बढ़ाना है, we have to increase the activity of vitamin D or concentration of vitamin D. What we have to do, we have to either improve the actions of PTH, or we should try to find patient's kidney function is properly obtained or not. So in better kidney function and in PTH, we can easily synthesize vitamin D. If patient's kidney is failed or patient's PTH is not responding, then this FGF23 antagonist should be given. Okay, we have to decrease the action of FGF23. In that case, we can improve the synthesis of vitamin D. I think you all are following me. Okay, you just try to remember these three mechanisms. PTH is improving synthesis of vitamin D. Kidney is helping in improving production of vitamin D, but FGF23 is decreasing production of vitamin D. Simple. Clear? I think till here you have understood. Now you see, now actual bisphosphonates concepts will start here. See, before understanding this, you should understand we have two types of bone cells. We have two types of bone cells. One is called osteoblast. Osteoblast. Osteoblast cells are denoted here with green color. Okay, green color. And we have second type of cells in bones. They are called osteoclast. Osteoclast. Okay, just only remember one thing. Osteoblast cells are bone synthesizing cells, bone forming cells, whereas osteoclast cells are bone degrading cells. You remember this term enough. Now you see, if anybody is having osteoporosis, osteoporosis means patient's bone is getting destroyed. Okay, osteoporosis means patient's bone is getting destroyed. That means patient's osteoclast activity is increased. If patient's osteoclast activity is increased, that means simple we can say that patient is having osteoporosis. Now what we have to do? In order to decrease osteoporosis in the patient, we should try to decrease the actions of osteoclast activity. Simple. Osteoclast activity कम कर दिया तो क्या होगा? Osteoporosis कम हो जाएगा. Now you see, here you see, we have some more proteins, same like FGF. FGF it is a protein actually. All these factors are proteins. They are factors. Tumor necrosis factor करके you might have heard. Okay, there are so many. These are proteinaceous compounds, proteins. Here we have one compound called RANKL. RANKL, याद रख लो. This RANKL, its full form you have to remember. Receptor, R means receptor activator of nuclear factor. Receptor activator of nuclear factor kappa B ligand. ये सब full forms you need not, it's not necessary for you. Just remember RANKL, MCSF and OPG. These three compounds. In these three, you know, RANKL and MCSF, these two factors will increase the differentiation of osteoclast. Let me repeat the point. RANKL and MCSF, these two factors, what they are doing? They are potentiating or they are improving the differentiation of osteoclast cells. Actually, osteoclast cells are differentiated from some monocytes from the stem cells. This monocyte is again differentiated into pre-osteoclast, and again it is divided into osteoclast. These osteoclast cells are the type of bone cells. When they are synthesized in the bone, slowly they will try to degrade bone. So to degrade the bone, who is indirectly helping? RANKL factor and MSCF factor. These factors, from where they are coming, you know, these factors are coming when osteoblast activity is increased. अगर अपने बॉडी के अंदर osteoblast बढ़ गया, always see, whenever our bone density keeps on increasing, it will not keep on increasing, you know. Bone density ज़्यादा बढ़ गया तो क्या होगा? Bone will break. At some extent bone will break. So we should never increase bone density. It should not cross its limit. एक particular limit तक रहना चाहिए, उसके ज़्यादा नहीं रहना चाहिए, because bones should be elastic in nature. Okay, bones का elasticity भी चाहिए अपने को. Elastic bones are always powerful and they have strength, whereas high density bones will break. See, When sufficient amount of osteoblast cells increases in the bone, immediately they will go and improve production of, they will produce RNKL and MCF. Again, RNKL and MCF, what they do, they will start differentiating osteoclast. So these both, जितने भी osteoblast produce हो रहे हैं, in the same manner osteoclast cells also should be increased. In both of these, if anyone increases or anyone decreases, bone density will be altered. Bone density alter होने के लिए these two are very important. See, in endocrinology also we need glucose and glycogen, insulin and glycogen both are required in same quantities. इन दोनों में अगर कोई एक बढ़ गया एक कम हो गया तो क्या होगा? Glucose homeostasis will not be maintained. In the same way, calcium and bone density also alteration occurs if any one of these cell is decreased or increased. I think you all are following me. Okay, see, first RNKL and MCF, these two are obtained from a sufficient amount of osteoblast, and these will differentiate increased osteoclast. When osteoclast increases, bone degradation occurs. Again, when bone degradation occurs, what happens? This degraded bone will again it will attach with the new osteoblast, and again new bone will be synthesized. Again, when new bone synthesized, the RNKL will be synthesized, again bone will be destroyed. Bone destroy होते रहता, calcium निकलते रहता, and new bone will be forming, bone will be destroying. All this is a circle process. And here what I want to tell you is, here PTH and vitamin D has two functions. याद रख लो, जिंदगी में याद रख लो, यहाँ पे confuse, you will confuse here. PTH and vitamin D both are showing differentiation action on both the cells, stem cells of osteoblast as well as stem cells of osteoclast. याद रख लो. See, in our body, just now I told, osteoblast cells are important and osteoclast cells are also important to maintain homeostasis. And to maintain this both the cells, PTH and vitamin D is needed. PTH and vitamin D, what they are doing, they are not only improving osteoblast, they are also developing osteoclast cells. याद रख लेना ये चीज. Okay, now you see, in some point of time, sometimes what will happen due to hormonal imbalance or due to menopause, what happens, some patients osteoclast activity increases. So in that cases, what will happen? Osteoclast activity will try to degrade the bones by removing calcium from the bones. That is called bone resorption. So here just now I told, there are some drugs, bisphosphonates, calcitonin and estrogens. They will go and act here to stop osteoclast activity, and they will try to maintain bones by decreasing the osteoclast activity, by degrading the bones. Okay, I think you understood this all mechanisms of vitamin D, PTH, osteoblast, where bisphosphonates are acting, where calcitonin is acting, estrogen. Okay, I think this slide is clear to you. I am going very slow. This image is from Shanbach. This is also there in Goodman-Gilman also. You can, yes, this is very simple. Ye to I think you understood. Okay, synthesis of vitamin D. Okay, now this is just a revision slide. I just explained you the importance of PTH, the actions of vitamin D, and actions of FGF23. What is FGF23? It is a fibroblast growth factor. What it does, it will stop the production of vitamin D, okay, or activation of vitamin D. Okay, yeah, see, let us revise the actions of PTH, vitamin D and FGF23. In the intestines, PTH and vitamin D has same action. They will improve the absorption of calcium. Yes, PTH and vitamin D both will try to improve or increase the absorption of calcium from GI tract. Next, PTH action on kidneys. From the kidneys, PTH will decrease excretion of calcium, and vitamin D also decreases excretion of calcium. याद रख लो, PTH decreases excretion of calcium and vitamin D also decreases excretion of calcium, because PTH and vitamin D should try to maintain calcium in the blood. दोनों का काम क्या है? Calcium, blood के अंदर calcium level should be maintained. Okay, so PTH and vitamin D both will try to maintain calcium level in the blood. And next, on the bones, PTH will destroy bone. It will destroy bone, whereas vitamin D will synthesize bone. This is one difference. This is main difference. So what PTH does? PTH will destroy bone, and it will try to bring the calcium into the blood. Whereas vitamin D, what it does? Vitamin D converts the calcium into the bones, into the bone. Okay. So this is one function. And net effect क्या है? दोनों का net effect is both PTH and vitamin D both will try to maintain calcium in the serum. Clear? Now FGF23 क्या करेगा? FGF23 will try to decrease here in intestine. What is its action? It is decreasing vitamin D. So what will happen? Decreased calcium and phosphate absorption is seen. Calcium कम हो जाएगा if FGF is elevated in the body. And on kidneys, what it does? It increases phosphate excretion. Okay, and decreased vitamin D production because it is decreasing vitamin D activation. And on bones again, it decreases mineralization, bone density kam kar dega. And finally in the serum, it decreases serum phosphate. Okay, so these are different actions of PTH, vitamin D and FGF23. I think this slide is also clear to you. Any doubt in this? Now you see, now this point is very very important. Dhyan se suno sab log, this slide is important. Now let us try to find out the pharmacokinetics of bisphosphonates. Okay, bisphosphonates के pharmacokinetics क्या है? Very very important. If you go and write competitive exams anywhere, from this pharmacokinetics only they will ask questions, not from the mechanism. From the pharmacokinetics they will ask questions about bisphosphonates. Number one very very important point about pharmacokinetics of bisphosphonates, याद रख लो सब लोग. Bisphosphonates are highly polar in nature. Bisphosphonates are highly polar in nature, same like all heavy metals, aminoglycosides, vancomycin, and we have so many other drugs. Likewise, bisphosphonates are also highly polar. Highly polar means drugs are not absorbed properly from GI tract. Yes or no? अगर drug highly polar है, highly polar drugs are not properly absorbed from GI tract. That's why most of the bisphosphonates are available in IV form, IV infusions. Some of them are available in tablet form also, but tablet form drugs are having very less GI bioavailability. याद रख लो these points. Okay. Now second point, very 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 important point. See, when bisphosphonates are absorbed from the GI tract or when it is given through IV route into the blood, the bisphosphonates in the blood, it will not metabolize in the liver. It will not metabolize in the liver and it is excreted unchanged. Unchanged. Why it is not metabolized? Because already bisphosphonates are highly polar. They are highly water soluble. That's why metabolism is not required. They are excreted unchanged from the urine. And another third very important point, yaad rakh lo, the bisphosphonates are having high affinity to, it has high affinity to accumulate in bones. They accumulate in bones. The non-accumulated bisphosphonates are excreted unchanged from urine quickly, whereas the accumulated bisphosphonates will stay in the bones from months to years. It will stay in the bones from months to years. सालों तक bone के अंदर ही accumulate होके रहता है. Bisphosphonates are accumulated in bones for years. This point you have to remember. That's why there is one drug called Zoledronate. Just now I told in example, Zoledronate is one form of drug which is available in IV form. It is mainly given in IV form because it is given in IV form because IV irritation is very less with Zoledronate, and this drug is given once in a year. It is given only once in a year. Why? Because when it is given once in a year, it will go and accumulate in the bones and it will stay for 1 year. एक साल तक second dose देने की जरूरत नहीं पड़ेगी. Okay, that is the importance of Zoledronate. And some other drugs are having their half-life or their duration as 1 month, 2 months, 3 months, depend on their concentration. Okay, just remember about Zoledronate, it is given once in a year. Okay, so these are important points about bisphosphonates in pharmacokinetics. And one very very important point, when bisphosphonates are given through oral route, they are, patient is advised to remain upside. When it is given through oral route, we have to advise the patient to stay for upright position. You know what is upright position? Patient को immediately we should not advise to sleep, or we should not advise to bend or do some activities or something. खाने के बाद we have to make the patient to stand like this only for up to 30 minutes. Why? Why we have to make this? Because bisphosphonates are having highly esophagitis. It will cause esophageal inflammation. Esophagitis cause karega. That's why we have to advise bisphosphonates if it is given through oral route, advise with lot of water. Number one, we have to go with lot of water, and number two, we have to make the patient to stand or stay in upright position for up to 30 minutes. These two precautions we have to take when bisphosphonates are given through oral route. Clear? So see, just imagine when bisphosphonates are given through IV route or through oral route, the drug enters into the blood and from there it goes and accumulates in the bone. So what is the action of these bisphosphonates in the bone? We'll go back to the mechanism. I skipped that point. See, bisphosphonates has 2 to 3 mechanisms. The first mechanism on the right side, you just see, this one is important. Bisphosphonates will go, just imagine this is a osteoclast cell. Wherever osteoclast cell activity increases, what will happen? Bone degradation will improve, right? Bone degradation occurs. So these bisphosphonates will go and it will accumulate in the osteoclast cells, and it goes and accumulates in the bones. And it stops, what it does, it will decrease the apoptosis of osteoclast. I mean, it will increase, sorry, it will increase the apoptosis of osteoclast cell. When osteoclast cell is immediately destroyed, what will happen? When osteoclast cell is immediately destroyed, what will happen? It will replace the bone, it will stay in the bone, and it will protect the bone. It will protect the bone from destruction. It will protect the bone from destruction. This is one mechanism. This is one mechanism of bisphosphonate. Number two, in bisphosphonates we have organic forms, organic bisphosphonates and inorganic bisphosphonates. Organic bisphosphonates means the bisphosphonates which contains amino group. Okay, amino group अगर उसमें है तो they are called amino bisphosphonates. If amino bisphosphonates or I mean if amino group is absent, then they are called inorganic bisphosphonates. Especially organic bisphosphonates which are containing ammonia group. In just you can see here also, see the bisphosphonates which are containing ammonia, I mean amino group here. Examples you can see, this one pamidronate, erythronate. Okay, so these examples, this one alendronate, and yes, again which one? So these are the amino group containing bisphosphonates are having this second mechanism. This mechanism is particularly seen with inorganic bisphosphonates, and this second mechanism, this is seen in organic bisphosphonates. याद रखो organic bisphosphonates क्या करेंगे? See, this is the mechanism of cholesterol synthesis. I think in biochemistry you have studied. HMG-CoA is converted into mevalonate. It is converted into phosphomevalonate. Again, phosphomevalonate to the mevalonate diphosphate, and again finally it is helpful in synthesizing cholesterol. All these mechanisms you might have studied. See, these organic bisphosphonates will go and inhibit the enzyme. Which enzyme? The name of the enzyme, you can zoom and you can see farnesyl pyrophosphate synthase, FPPS. This enzyme is inhibited by ammonia containing bisphosphonates, and when this enzyme is inhibited, cholesterol synthesis stops and all other cholesterol related mechanisms will stop. When this mechanism stops, what will happen? Actually this cholesterol and all these mechanisms are useful for increasing osteoclast activity. Cholesterol and all these mechanisms are useful for osteoclast activity. When this enzyme is inhibited, what will happen? Cholesterol and all these mechanisms decreases, and obviously osteoclast activity also decreases, and through that we can save the bone, or we can decrease the osteoporosis. Osteoporosis can be decreased through this mevalonate pathway. So this is one mechanism, directly it accumulates in the osteoclast and it will save the bone, and the second mechanism, it will stop the action of this enzyme, and through that it decreases the cholesterol activity. Okay, so these are two mechanisms, and along with this many other mechanisms are also there, but remember these two mechanisms, through this it will decrease osteoporosis. I think you understood the mechanism. Clear? Pharmacokinetics is also important. Now the important point is adverse effects. Bisphosphonates के adverse effects क्या है? Number one, bisphosphonates causes nausea, vomiting, sometimes diarrhea, and very important, it causes stomach burn or heartburn बोलते हैं, HEART, epigastric region में burn होगा, heartburn, epigastric region burning sensation. This is GI related, and especially याद रख लो, bisphosphonates causes esophagitis, and it causes or it aggravates peptic ulcer. Very important. These two are very important adverse effects of bisphosphonates. If anybody is taking bisphosphonates through oral route, it causes esophagitis and it aggravates peptic ulcer, or it causes peptic ulceration. Sometimes it causes fever also. It causes flu-like symptoms also. But ये सब secondary, fever, flu-like symptoms, heartburn, diarrhea, nausea, vomiting. These are all okay, but very important one is it causes esophagitis. Very important. Esophagitis and peptic ulcer, these both the adverse effects are decreased by advising patient with lot of water. We have to advise patient with lot of water, and we have to make the patient to remain upright position for at least 30 minutes. Clear? So adverse effects, esophagitis is very common, peptic ulcer is very common, and to overcome these adverse effects, we have to give lot of water to the patient, and along with that, after taking tablet, we have to make the patient remain upright position for 30 minutes. Very important point about bisphosphonates. So these are the adverse effects and uh, points to be remembered in adverse effects. Now you see uses of bisphosphonates क्या है? Simple, bisphosphonates are mainly used in Paget disease, just now I told. Next, bisphosphonates are drug of choice in postmenopausal cases. Postmenopausal cases. Okay, in postmenopausal cases, if anybody has non-tolerative hormone replacement therapy, if hormone replacement therapy fails, or if patient has hypertension, or if patient has anything adverse effects associated with hormone replacement therapy, if hormone replacement therapy is failed in postmenopausal condition, bisphosphonates will be drug of choice. Next, bisphosphonates are used in corticosteroid overuse. Corticosteroid overuse, osteoporosis. You know, corticosteroid overuse करने से osteoporosis आएगा. Osteoporosis is occurred if patient has corticosteroid abuse. Okay, in that cases bisphosphonates are drug of choice. And another very important use is, see, there is one very important condition called hypercalcemia due to there are some conditions, cancer conditions. Okay, hypercalcemia due to cancers. In this condition, bisphosphonates are drug of choice. Okay, this is very important point. If anybody has hypercalcemia due to cancer or due to any other condition, so in hypercalcemia, especially along with bisphosphonates, there is one antibiotic, or there is one anti-cancer drug which is called मिथ्रामाइसिन. सुने आप लोग? रोमिल, I think you heard about मिथ्रामाइसिन. Doxorubicin, मिथ्रामाइसिन, bleomycin, all these drugs are anti-cancer antibiotics. एक्चुअली मिथ्रामाइसिन का एक एडवर्स इफेक्ट क्या है? इट कॉजेस हाइपोकैल्सीमिया. याद रख लो, मित्रद्रोही. मिथ्रामाइसिन, व्हाट इट डज? मिथ्रामाइसिन विल डिस्ट्रॉय बोन्स, सेम लाइक corticosteroids. Okay, so mitromycin is an antibiotic, anti-cancer, and it is also sometimes used in immunosuppressive conditions. So mitromycin causes hypocalcemia. So this adverse effect is used in hypercalcemia in some cancer conditions. That's why mitromycin along with bisphosphonates can be used in hypercalcemia conditions. याद रख लो this point. Okay, so these are some uses. It is used in Paget's disease, postmenopausal condition, if hormone replacement therapy is failed, corticosteroid overuse, in that conditions osteoporosis, in that bisphosphonates are used, and in hypercalcemia due to cancer conditions. Okay, this is these are uses of bisphosphonates. Now, individual drugs, it is not necessary to study about all these drugs. All the drugs will have same features. Okay, they are having, if they are given through oral route, they will have high esophagitis, peptic ulcer, irritation property रहता. GI irritation is commonly seen, nausea, vomiting is seen. Patient can't tolerate if they are given in oral. So in oral, if they are not tolerated, they are available in IV form. Okay, pamindronate is commonly available in IV form. Usually 90 mg dose is given. In 10 ml 90 mg रहता है. In 1 ml 9 milligrams. Okay, so 90 mg, 60 mg, 30 mg vials we have. Okay, so you can just see the pamindronate different formulations. This is the chemical structure of pamindronate. Yeah, here you again I have taken from Katzeng pharmacology textbook. You can see this is inorganic one. Inorganic, here we don't have ammonia group. Okay, so inorganic pyrophosphate or bisphosphonate. This is etidronate. See, etidronate is inorganic. Pamidronate and alendronate are organic forms. These are organic because they have ammonia group. So these ammonia groups are having one additional property. What? It will decrease the synthesis of cholesterol. Okay, in mevalonate pathway, and through that it decreases the activity of osteoclast activity. By that also they will improve. I mean, this cholesterol will increase the osteoclast activity, and when we decrease cholesterol, what happens? Osteoclast activity decreases, and through that we can maintain bone density, or we can decrease osteoporosis. Okay, so this is the difference between organic and inorganic. This one already I have explained, just for understanding I have. And next one is oral form, alendronate. Oral tablets are available, 70 mg, 35 mg. These alendronate are having more GI irritation property. Most patients will not tolerate. They can't tolerate. Toleration property is very less. If it is given through oral route, what we have to do? We have to give more water and always advise the patient to stay in upright position for some time. Okay. And zoledronate. This one is important. Zoledronate is important. Zoledronate is available in both the forms, but mainly it is available in IV form, IV infusion. जोलेंड्रोनेट के बारे में क्या बताया था आपको? इट इज गिवन वंस इन ए ईयर, एक साल में एक बार. Okay, and we have some other forms. Etidronate tablets, 200 mg, 100 mg, 50 mg, and we have risdronate 150 mg, 75 mg tablets are available. So these are different examples of bisphosphonates. We have seen their examples, their tablet formulations, IV forms. We have seen their uses, their adverse effects. A very important one is oesophagitis, and we have seen their pharmacokinetics. They are highly polar in nature, and they are excreted unchanged without metabolism, and they are accumulated in the bones for a long period of time, up to years. And we have seen some basic physiology of PTH, vitamin D, FGF23, their actions. Vitamin D synthesizing process. We have two pathways from plant sources and animal sources, and other concepts. Okay, so these are different concepts about bisphosphonates. I think you learned something from this lecture. Okay.